So welcome and thank you for joining us on behalf of the Midwest AIDS Training and Education Center. We're headquartered at the University of Illinois College of Medicine at Chicago, Department of Family and Community Medicine. This program is being recorded and will be available later at our website. I will also send everyone a link later on. Today's program is part of a series that started on April 7th with HIV and infant feeding in the U.S. Part 1, Where Are We Now? The recording is now available, and I'll include the link in the follow-up email. We will start with a short presentation followed by our panel discussion and lastly, the Q&A. Please type your questions in the Q&A box, not the chat box, please. And we will address them in the Q&A segment later on. Please note your responses to the polling questions are anonymous. And now I'd like to welcome Ann Stanton from the Mother and Child Alliance. And I also want to thank Ann for proposing this collaboration to MATEC months ago, and now we are here. So thank you, Ann. Ann?
Welcome, everybody. We are very excited to be helping to bring this webinar to you today. So Dr. Jennifer Zhao is with Lurie Children's Hospital and also Northwestern Memorial Hospital. And I'll let you give a more formal introduction of yourself. But she's going to start out by telling us a little bit about what is new in the guidelines. And we can go forward from there.
All right, welcome. Thank you for joining us with this second round and hanging in there with us. We're going to do the first part of this as sort of a lightning summary to bring you back up to speed on what we spoke about last week. Sorry, not last week, last session. And then devote the rest of this time mostly for Dr. Yee and our panelists of interviewees. So without further ado, okay, this is just a nursing C&E statement and then a MATEC statement that we want to make sure you all know. MATEC is committed to equity and inclusion, and we take this stance very seriously. So we're hoping that if you find anything offensive in the way our presentations have gone today, please let us know. This disclaimer that we have to put up, and then we've listed all of our speaker disclosures, which are none. And so what we want to do for this session today is a couple of objectives. One, we want to make sure that you can walk away and sort of describe in a few bullet points what are the key changes in the 2023 DHHS perinatal guidelines recommendations for infant feeding. We really want to recognize the roles of physicians, nurses, providers, social workers in supporting birthing parents and their infant feeding choices. So that's going to be what we'll focus in on for the second part of this session. Hopefully you'll walk away understanding sort of the reasons why persons with HIV might desire to choose to breast or chest feed and how we can come up with strategies to support them. And then lastly, we'd like to inundate you with resources available for persons with HIV if they're undergoing sort of the decision to choose whether to choose breast chest feeding. So like our last session, I'd like to start with a initial polling question and just sort of type into the polls which field you'd like to choose. Really, the question is, what is your primary professional practice area? So you might be in several of these, but just choose your primary one so we can get a sense of our audience. Okay, so we have quite a few ID and OB, very few internal medicine, a little bit of family practice. And then we have a big chunk that says, I am not a healthcare clinical professional. Great, this will be an interesting conversation then, I hope, today. All right, let's keep going. If you feel like typing into the chat what your specific role is in a text, if you had clicked the one, I am not a healthcare professional, I think that might help us get a flavor of who's out there today. So our second polling question is, how comfortable are you discussing breastfeeding with your patients or clients?
Yeah, we're getting some also responses in the chat box. Nurse case manager, development manager, et cetera, case managers.
Yeah, prep nurse, case managers. This is great. Oh, HIV program analyst. That's neat. Community doula. This is exciting. We've got a lot of, okay, so we have closed our poll to question 2. Looks like in the middle there. Good, we don't have anyone that's very uncomfortable. We have a couple that are uncomfortable but can discuss it. So great. Great, a little bit of room to improve and learn today then. Okay, I just want to spend a couple seconds on this slide and let you know, we do try to describe infant feeding in terms of breast/chest feeding. When we counsel individuals with HIV about infant feeding, we also try to be sensitive to the terminology that would best be appropriate. I might mess up today as I'm going along with the slides, and I'm just going to ask for forgiveness up front. But when I'm discussing, let's say, a research article or a study where cisgender women, or we know that they were women involved in that study, I may revert to the term of women or breastfeeding. We also try to use gender inclusive language here in recognition that we know not everyone who gives birth or feeds a baby identifies as a woman. And I am definitely going to try to use people first language for persons living with HIV. In fact, I think the CDC has adopted the term PWH, so persons with HIV. Okay, so like I said, the guidelines have really evolved on breastfeeding. We went over this in the last session, but just to give you a high level look, we took these sort of 4 pillars of issues, dialogue with community members. We had some ethical considerations, spoke with ethicists, thought about health inequities within populations struggling with HIV, and then, what does it mean to do shared decision making? And all of these sort of pillars came together to help us on the guidelines come up with what you have now in the January new edition of infant feeding. And it was a long road. And in our last session, we went through a little bit more in detail, but just to let you know, the guidelines have not just changed willy-nilly out of one person's sort of decision, but it really has taken a long road of several thinkers. One of the big questions we often have and have struggled with as we were thinking about guideline changes was, does the U equals U in sexual transmission, horizontal transmission, if you will, does that also apply for lactational? We know it does for sexual, and then we also know for perinatal that no transmissions usually occur if a pregnant person on ART is taking that ART and adherent during pregnancy and before pregnancy. But what about when a woman is lactating? If that person is undetectable in the plasma or blood, does that also mean the breast milk is undetectable? There's a couple of forms of HIV that you can find in breast milk. And on the left-hand side here, we're going to talk about cell-free HIV. And that's by and large, the HIV that we all measure in our blood that's circulating. It's running around in the plasma, and there is a component of that that's also in the breast milk. So when you measure HIV RNA or a viral load, that is what we're measuring, the HIV that's not bound to a cell. So we know that when you take ART, that is going to suppress the cell-free associated HIV in your breast milk. There's also something called cell-associated HIV. So that's HIV that's in a resting T cell. Most likely those T cells are in your latent reservoir. And we know that there is cell-associated HIV as well. And when you take ART, you can't suppress the cell-associated HIV in breast milk. You can't actually get at it. The ART can't get to it. So the cell-associated HIV that we do find in breast milk is actually 10 times more efficient at activating in milk than in plasma. So we worry about the cell-associated type of HIV that's bound to the T cell, which we can find in the breast milk, that is not there in the circulating plasma. So that is what gives us pause when we have, for the last few decades, worried about breast milk transmission. So here are a couple of bullet points. The new infant feeding guidelines are several pages long, but we've tried to distill the most important nuggets for you to sort of chew on. And I'd say the first nugget here is long, and I don't want to read the whole thing, but the key takeaway is that persons with HIV really should receive evidence-based counseling and really should undergo a support shared decision making when it comes to infant feeding. We think that counseling shouldn't happen after the baby's already born and you're scrambling to assess what the mother or the birthing parent wants to do, but really start these conversations early and give as much information as you can for the shared decision making process during the antenatal period. Another key takeaway from the January guidelines was that we want folks to know replacement feeding with properly prepared formula from a milk bank actually does eliminate the risk of postnatal HIV transmission or breast milk associated transmission. However, we also want you to know that if you as a mother or a birthing parent can achieve and maintain viral suppression with ART adherence throughout pregnancy and postpartum, you can decrease the risk of breast milk associated HIV transmission to about 1%, but it's not zero. So just because a person might be able to take ART, maintain adherence, and be viral load undetectable throughout breastfeeding, it doesn't eliminate the risk of breast milk associated HIV. Okay, so what do we do when we say, gosh, you need to start talking about it in the antenatal period? Well, we try not to do sort of a hard line judgmental attitude. When you do that, we've obviously noticed that our patients or our clients just decide not to tell us that they're going to breastfeed. I think they may also decide they're going to breastfeed or chest feed intermittently, which actually doubles the HIV transmission risk. We really try to understand what's the context behind why the person might be considering breast or chest feeding, because I think understanding what their motivations are helps you to have a well-rounded conversation. It's important to really validate their desires, educate their risks and benefits, but understand where they're coming from. And we try also not to dumb down things. If they want as much hard science as they want, we're there to give it. If they also don't want that much in terms of hard science, and I've had some people just say, just Dr. Howe, what do you think the gut feeling is and what would you tell me if it were you, right? So sort of understanding how much and how little information they want and in what context they want it is always helpful. These are a couple more nuggets that we're gonna put out that I think I'd like to highlight from the recommendations if you can't read the entire thing. So it's important that we felt for sort of us to make known that individuals with HIV, if they're on ART and they're virologically well controlled and they choose to breastfeed, we really should try to support that decision as best as possible. And engaging child protection services, which has happened across the nation, is really not an appropriate response to an infant feeding choice for an individual who's living with HIV. A couple of things you might want to address as the woman is considering breast or chest feeding. We need to tell her about mastitis and to look out for that, because when you have mastitis, it's going to increase the levels of virus in the breast milk. We really also recommend exclusive breast or chest feeding up to 6 months of age. As well, we highly, highly recommend just consulting the pediatric and obstetric infectious disease specialists when you're trying to think through the details of who, how long, and when does the viral load monitoring have to happen for the birthing parent? How often then should the infant PCR testing happen? Do we need to add any additional ARV prophylaxis to the child? When's the best time to wean? And then how do you monitor for mastitis? How do we support them for adherence? We went over a lot of this in great detail on the last session, but I just wanted to highlight some of these key points in case folks want to go back. So in summary, counseling decision about infant feeding choices really should occur during the antenatal period. And we try to do this, of course, with a non-judgmental manner and present very evidence-based recommendations. We know that breast milk associated HIV is very low when the breastfeeding individual is virologically suppressed, well controlled with excellent adherence, but it's not zero, it's not eliminated. And really the only way to eliminate the risk of breast milk associated HIV transmission is through formula feeding. Lastly, I can't tell you how much we stress and highlight the importance of coordinating your obstetric and pediatric infectious disease specialists together in supporting the individuals who choose to breast and chest feed. And with that, I think I will hand it over to Dr. Yee. Or actually, I'm going to hand it over to Anne, who's going to introduce Dr. Yee.
Thank you so much, Jen. That was great. You can make a note of your questions. You can pop them in the Q&A, and that's helpful if you don't want to kind of lose your place on something that Dr. Zhao said that you want to ask a question about. But I wanted to finish the rest of my introduction because I couldn't find it before, and to let you know that this is really a collaboration, which Estella had said, between Maytech, the 24/7 Perinatal HIV Hotline, and the Mother and Child Alliance. And of course, we want to thank Lori Ayala from the 24/7 Hotline in helping us to develop this collaboration and to help bring this program to all of you. For those of you who are less familiar with the hotline, it is a 24-hour resource for Illinois clinicians and social service providers who are offering expert medical consultation, access to social services, and care coordination for vulnerable people who are pregnant and also for their infants. The hotline provides a single point of entry into care for pregnant people who are living with HIV and real-time linkage to specialty obstetric, HIV, and PEDS care. The hotline also acts as an official reporting mechanism for the state of Illinois for rapid HIV tests that are performed on pregnant people at labor and delivery, and also triage. The hotline is funded by the Illinois Department of Public Health and staffed by physicians, public health professionals, and social service care providers from the Northwestern Memorial Hospital, the Ann and Robert H. Lurie Children's Hospital of Chicago, the University of Chicago, and the Mother and Child Alliance. Mother and Child Alliance, if you're scratching your head and saying, these people look familiar, but that name is new to me, we changed our name right at the end of 2019, before the pandemic, just to make things even more confusing. We used to be called PACP, the Pediatric AIDS Chicago Prevention Initiative, and our mission was to eliminate deaths from pediatric AIDS and the transmission of HIV from mothers to their children. Our current mission is to reinforce a safety net during and after pregnancy for birthing parents, babies, and their providers to prevent HIV and other serious, costly pediatric infections in newborns. We are also funded by the Illinois Department of Public Health. We provide comprehensive support to pregnant people and their families through community-based social services and strong linkage to medical care that is offered in a respectful manner without judgment or bias. We do this statewide, and we engage with our state and national partners to identify gaps in existing services and address those barriers and solutions to strengthen perinatal HIV care. In introducing Dr. Yee, she is the Thomas J. Watkins Memorial Professor of Obstetrics and Gynecology, a tenured associate professor in the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology at the Northwestern University Feinberg School of Medicine. She's also the Associate Chief of MFM for Research and the MFM Fellowship Program Director. As a clinician, Dr. Yee provides full-scope maternal fetal care with particular interest in HIV. She is the director of the Women's Infectious Disease Program at Northwestern Memorial Hospital and the medical director of the 24/7 Illinois Perinatal HIV Hotline. As a researcher, Dr. Yee leads a large NIH-funded research program addressing issues of health equity, health disparities, and health services in obstetrics and postpartum health. And with that, I invite you to please welcome Dr. Yee.
Thanks, Anne. I am delighted to be here today because this topic is so important to the care of people with HIV and their children. And we've been having, as clinicians, more and more calls about this, as hotline staffers, more and more calls about this, on the hotline and in the patient setting. And so it is increasingly recognized as a key part of comprehensive antenatal care of pregnant people with HIV. So I want to just briefly go over some of the motivations that individuals have to breast or chest feed their infants before we then dive into a conversation with our experienced case managers. Probably many of you as case managers, public health professionals, and clinicians have seen some of these motivations. What I want to share with you today are some direct quotations from patients that have been published in rigorous qualitative literature, but I hope that some of these comments will resonate with you if you cared for any people who've been considering these things. So first, there are a number of considerations that any person, any new parent decides when they are thinking about breast or chest feeding. And one of those is the emotional aspect to the decision making about infant feeding. On the left bubble, you can see a person who said the baby that breastfeeds, they have more love than the baby who doesn't. And another person contrastingly says, similarly says, I accept it. It pains in my heart. It pains me because as a woman, you have to breastfeed your baby. So it pains her to not breast or chest feed her infants. And these emotional considerations are a substantial reason why many individuals choose to breastfeed. Secondly, there are a number of social considerations as well as disclosure concerns. For example, on the left, someone says, it was difficult. I had so much company coming over here when I first had the baby, and they all asked me why I wasn't breastfeeding, every single person. So for individuals who have not disclosed their HIV status to the people in their family or their social circle, not breastfeeding may open up questions to their community members. And this may be particularly true for perhaps immigrant mothers for whom the non-breastfeeding would serve as a form of disclosure, such as the comment on the right. It's so sad because most people, like most Africans, they know that the moms who do not breastfeed are moms who have HIV. They know that. So sometimes if they're coming to your apartment, they'll be watching to see if you're going to give the baby milk. And I will say, as a clinician, this is something that Dr. Howe and I encounter all of the time. This is a very frequent concern around not breastfeeding. And although an individual may decide she may not desire to breast or chest feed, there may be this strong familial and community pressure to do so for these reasons. Next, there are a number of important maternal and child health considerations, and we're not going to get into this in depth because I think this audience is probably very familiar with the concepts that breast milk is considered the ideal form of nutrition for neonates. And people will say, such as this person here, I wanted to breastfeed because from what I read in all the books, breast milk was best, so I wanted to give my baby breast milk. We also know that formula is very high quality, and in places like the United States, we have access to safe water and really FDA approved formula formulations. And so formula is an equally good opportunity to provide healthy nutrition to a neonate, but yet there is still things that cannot be passed in formula, such as maternal immunoglobulins and immune protection. And mothers often know this and bring up this comment with us when discussing it. Next is the financial cost to not breast or chest feeding. Anyone who's ever had a newborn understands this concept, that it's a lot of work, sterilizing, washing, boiling water, and they mean this for the sake of formula feeding. During the nights, I'll get up stressed because I have to get up and boil water all the time if he cries or if he needs to drink. I think probably you all are familiar too with the recent shortages in formula that have happened in the United States. And although we've recovered from that, it remains an issue that for many parents can be quite stressful, thinking not just about buying the formula, but will the type my infant needs be available at the time that I need it? And will there be sufficient quantities? So the financial and logistical challenges of not breast or chest feeding are also substantial, as are sometimes the challenges of breast or chest feeding itself, particularly when you think about cleaning pump supplies. Next are the concerns about potential infant feeding coercion. This has come up in a number of papers that you can see, one of which you can see cited there. One person said, I was always told since my first pregnancy that I could only formula feed. When I continued to inquire about it, my nurse said to me, do you want to give your child HIV? Then you can't breastfeed. I was so hurt by this response, I haven't inquired since, even after multiple children. I'll let that sit with you for a moment because I think that that comment is unfortunately quite common. And one of the directions in which we hope to move based on these new guidelines is in a really more patient-centered open discussion about these issues. Another person said, I was told to bottle feed without any concern about my family history or culture. I feel as if my HIV status played a big role in the care and treatment I received surrounding breastfeeding. This was very difficult for me because I was made to feel as if I did not have a choice if I wanted a negative baby. And ultimately, one of the most important messages we want to convey is that people do have a choice, but that choice needs to be informed by the evidence and data regarding the risks and benefits of breast or chest feeding versus formula feeding. So I will leave us with this slide about motivations to breastfeed or chest feed and what versus motivations to formula feed. Among the benefits of breastfeeding include the health benefits, both for the birthing person herself, who is likely to experience a reduction in risk of cardiovascular and metabolic conditions in the future because of breastfeeding. For example, heart disease and type 2 diabetes risk is reduced among people who breastfeed for 6 months or greater. And for infants as well, such as allergy risks and other neonatal complications. Bonding and the emotional experience of breastfeeding or motivations to breastfeed, as well as cultural expectations, signaling the HIV status and disclosure concerns, and then lower cost. But in contrast, there are a number of motivations to formula feed as well. And this may include avoiding HIV transmission. And as Dr. Howe spoke about, the only way to guarantee not transmitting HIV in the postnatal period is to formula feed. There's also the convenience of formula feeding and that you can share feeding duties with other members of the family or co-parents. In addition, in our US society, we've limited support for breast or chest feeding, and many birthing people have to go back to work very early in the postpartum period. It may not have adequate protected time in their workday for pumping and storing milk, and this can be a major barrier to breastfeeding for all individuals, not just individuals living with HIV. And then finally, there's anxiety about potential transmission. And even if the transmission risk is very low, as we've learned in our last webinar, if the anxiety around that transmission outweighs the emotional benefits of of actually breastfeeding, it may not be worth it for some individuals. So I will end our brief presentation there because I really want to give some time to our discussion. I'm going to introduce our speakers in a moment, but what I'd like to do is actually share with you these resources and then stop slide sharing so that we can see all of your lovely faces on our webinar. These are some resources that you all will have available to you through the National Clinician Consultation Center, the MATEC, the hotline as well. And these slides will be available in the final webinar recording. So I'm going to stop screen sharing so that I can see Belinda, Stephanie, and Deborah. I'd like to invite each of you to briefly introduce yourselves, and I then will ask questions of the group about your experiences caring for individuals living with HIV who may be interested in infant feeding choice discussions, and then we'll welcome questions from our audience. Can I start with Stephanie? If you're able to unmute. Yes, you are.
Yes, it worked. Hello, everyone. My name is Stephanie Silver. My pronouns are she, her, hers. I am a Ryan White Part B case manager working out of Champaign-Urbana Public Health District, and we serve 17 counties in East Central Illinois. I have been in this role for about 7 years, and about 2 years ago added duties of a perinatal case manager as well.
Belinda?
Hi, I'm Belinda Richardson. I'm with MACA, or Mother and Child Alliance. I've been in this role now for 18 years, and it's my pleasure to be here. My pronouns are she and her.
And Deborah?
Hi, my name is Deborah Colquitt, and I am the Ryan White Perinatal Case Manager for Project ARC, and I service the St. Louis metropolitan area as well as the southern part of Illinois. I've been in this role for 19 years, and my pronoun is she, her, and hers.
Thanks, everybody. I am so excited that we have all of your experience, decades of experience here caring for pregnant and postpartum people with HIV and their families. I want to start by asking you all about some of the evolution in conversations you might have seen over time. And what are some of the questions that clients are asking you about infant feeding now, and perhaps how has that changed?
Well, now they're asking, can I breastfeed and what are my options to breastfeed? And so we're super excited about the new guidelines, even though in the past we probably had some that was very persistent about breastfeeding. And so since we know we had studies in other countries, we had to go off of that. But yeah, that's some of the things they're asking. What are the options?
And for me, it's been, well, now that we can breastfeed, what are the chances of my child becoming infected or not? And if I start breastfeeding and I decide to wean off, how do I do that?
Mm-hmm. Weaning is a really important question. Stephanie?
Well, considering I haven't been in this field for as long as my two co-panelists, I haven't personally witnessed much of a shift. I think the folks that I've been working with have either kind of thought, since they initially got pregnant with their first child, this isn't something that my provider is encouraging me to do, so I'm just going to stick with formula feeding for my other children. Or folks who are newly diagnosed and newly pregnant, they're coming into this world kind of knowing that this is a possibility already, so they haven't had to have that shift, if that makes sense.
Yeah, I've experienced that myself with caring for patients who had pregnancies with us 5 years ago. They have a kindergartner now, and the counseling was quite different then, and now they're pregnant with us now, and we're approaching it differently than we were. And so I think we all are feeling this this change, and whereas other patients are coming in for the first time having this experience. Related to that, and actually, Belinda, I want to come back later to your question about weaning, because I think this is something the audience will probably be really interested in Dr. Howe's advice, but I'm just going to sort of put a pin in that for a moment. I want to ask you all, when clients ask you these questions about, can I breastfeed, chest feed, and what are the risks of transmission? What's your impression of whether they're asking primarily you or whether they're also asking their clinicians? And what can we do to encourage these clinician-patient discussions?
Well, I've had 2 patients in particular to ask me about the breastfeeding, and both of them had previous conversations with their healthcare providers. And so it was an easier transition to discuss because they came to me with questions. It was like, well, my provider said I can now. Both of them have had children previously, like you said before, and there's a shift. So now it's like, okay, we can breastfeed. And my doctor was talking to me about this, and, I'm kind of excited, but I'm nervous. Can you tell me more? So fortunately, so far, these 2 young ladies have had prior conversations from their healthcare professionals or providers.
And I know for me, they're having just having the support of the providers. I know in my experience, I've had 2 that had the support. And so they were very excited about the support and then started having more personal conversations with me about it and just telling me emotionally how they feel about it. And sometimes they straddle the fence. And then once I talk with their provider with them, they feel a little more comfortable in going forward with the decision.
Can you, any of you, tell us a little bit about your clients' motivations to breastfeed and what's driving some of their decisions?
Well, one of the motivations for me is one of the moms had said when I had my other children, I wasn't able to breastfeed. And so now I'm thinking about having another baby so that I can have that bonding experience to breastfeed. Others is motivations, like you had said in the slide before, financially. This is going to take off the financial burden of trying to get formula, and they can breastfeed from there.
And for me, it was more of a health motivator. Both clients were struggling with their adherence, and they both were saying, you know what, this could be another motivation for me to stop smoking so much, to maintain all of my appointments, because now it's another level of caring for myself and my child. So that's a big motivator.
Do you think it worked? Did that person, was she able to refrain from smoking during breastfeeding?
They have both slowed down. They're admitting that it's difficult to just stop, but they have slowed down, and they're both are undetectable.
Yeah. I think it's a really important message that we consider pregnancy and the postpartum period to be a really important window of opportunity to improve health for birthing individuals, for a couple of reasons. One is sometimes people only have access to healthcare or regular access to healthcare during pregnancy. But 2 is that people are motivated during pregnancy and the early postpartum period to improve their health. So sometimes, like you're saying, the changes in health behaviors that you make during this period can have lifelong implications.
Yes.
Yeah, just that bonding and nutritional experience too that they'll have with the baby this go round.
Yeah.
And then another point is with the patients that weren't able to, especially the foreign patients that I have, now they're not feeling as ostracized. And so that's a big motivator as well.
And I love that. I love that for especially from my African clients. I love that so much for them.
Yes.
Can you share any stories of the patients who felt that stigma about not infant feeding. And in particular, one of the things that as clinicians we worry about is if there is sort of secret intermittent feeding by breastfeeding. And that's, as Dr. Howe mentioned, intermittent feeding is a risk factor for transmission. So we worry about that substantially. Have any of you had that happen with your clients in the past?
Yes, I unfortunately had a situation where my client, she felt like she had to breastfeed because her mom came to visit her from Africa. And so the baby did end up becoming infected.
Oh, that's
That was
devastating.
That was devastating. You know, she did it secretively. The first few tests were negative, and then that third one was indeed positive.
So we knew that it was a postpartum or breastfeeding transmission.
Yes.
I think this is one of the reasons why this conversation needs to be so open and transparent at the beginning of antenatal care and all throughout the care process, so that we can help anticipate these issues. And it would be far better to support somebody in a breastfeeding choice from the beginning than have that risky intermittent feeding 3 months in or 2 months in when a in-law, or somebody comes to visit. Stephanie, did you want to comment anything else on the motivations to breastfeed?
I think I've had similar experiences as everyone else. My most recent individual that I had this conversation with, her motivation was cultural. She comes from a part of the world where folks breastfeed regardless of HIV status, and it was hard for her to understand why her providers weren't recommending this, why there was a lack of support.
Mm-hmm.
And we did wind up having a conversation about, all of the nuances and ins and outs of breastfeeding, as well as barriers. Because providers weren't comfortable supporting her in this, it created additional barriers if she did decide to breastfeed. Ultimately, she decided not to do it. And then we had to have a conversation of, okay, what are those conversations with your family going to look like then? Because they are going to ask questions.
Mm-hmm. You segued right into the next important topic, which is that many clinicians are still adjusting to the change in recommendations. And I think especially in the United States, where it has been our cultural and until recently guideline-based practice to recommend not breastfeeding, many clinicians feel uncomfortable with change and may not have the expertise to be able to counsel a patient about all the pros and cons and how to manage breastfeeding well. And I think this can lead to difficult conversations for motivated patients. And I'm wondering what your experiences have been talking to clinicians yourselves as case managers, and if you have any advice for other case managers who might be similarly serving as a patient advocate or facilitating some of these shared decision-making conversations.
Well, on this end, fortunately for me, we've been meeting all of the teams, the OB team, Peds ID, Adult ID. So we've been having those meetings so that we can come up with protocols, so we can streamline those protocols, even though we know it's going to vary from patient to patient, but at least we'll have a streamline to go off of.
Yeah.
So, and I was just super excited to learn that the OB department was already talking with clients about breastfeeding once the guidelines came out. So it was an easy walk-in for me, to even start talking about it even more. And we have one great candidate, and I think she's going to do extremely well because she was virally suppressed before she got pregnant and been virally suppressed for a long time. And so this is an opportunity for her to breastfeed, and I believe she's going to go forward. At first, she was teeter-tottering with it because she ended up having a viral load of 20 and was like, that's great because you can still breastfeed. That's still considered being undetectable. And so she felt much more comfortable with that, with the whole team around her. But we've been having those meetings, and we're going to continue to have those meetings and a case study so that we can grow even more with it and feel much more comfortable with it.
Yeah, for me, I've had both a positive, like she said, support from the physicians, and then one client said the first physician that she spoke with asked her flat out, "Are you crazy? Are you crazy? Are you trying to, infect your baby?" And so when she came back to me, I was able to then go back and talk to that physician and give advice and who to contact as far as the updates. And so now that same physician is on board with it.
But that is saying, are you crazy? That is really a way to shut down an open conversation with a patient.
Yeah.
And so I'm so glad she
Yes.
had you.
Yeah, me too.
I think it's actually really key. We have a lot of case managers in the audience today, for our case managers to feel empowered to tell clinicians who may not be as familiar with the guideline changes about what the guidelines say. That is not to say that all patients need or desire to breast or chest feed, but it is, I think you serve a really important role to help clinicians stay, especially those who might not be, here today or in an academic medical center or surrounded by other HIV care providers. It's really an important role for the case managers to help clinicians know what the latest and greatest is with regard to the guidelines.
Yes.
Yeah, absolutely. We need to continue to advocate for our clients just like we do every day with everything. This is just another thing that we can help, advocate for them. I think one of the most important things is just having a really good relationship with your medical care teams in whatever area you have for service. I have a great relationship with our major medical provider, and I'm looking forward to having conversations with them about these updates to the guidelines. And I think that it'll just result in better outcomes for the folks that we serve who have a desire to do this.
Mm-hmm.
And I'd like to,
go ahead.
And I said early on, we had a mom before the guidelines who was insistent on breastfeeding. And so our OB team really assisted her with that and found out information. And so when she was persistent, who are we to tell her no, if all we can do is find the information to make sure that she do it safely, and she did do it safely.
Yeah, you bring up a really important point about harm reduction. We would much rather support a person in doing it as safe as possible than let it happen anyway without all the clinical and social support. I want to ask, what are your perspectives on the different experiences you've had with OBs versus pediatricians, or maybe versus family medicine, the different types of people who might interact with the mother-child dyad in this time period? And do you have different advice for different types of care providers depending on what field they're coming from? For example, by the time the baby's gotten to a pediatrician, many times a decision has already been made. And so I think that it's key to initiate these discussions early on with the obstetricians so that they're preparing for the decision in advance. But then I imagine one of your roles as case managers is to ensure that there's good communication between the general pediatrician and a person like Dr. Howe, a peds ID specialist, so that all parties are involved together to provide the best sort of 360-degree support to patients. But I think, maybe Dr. Howe could speak to this. I think that probably there's different needs and perspectives on this based on whether the person you're working with is an OB or a pediatrician.
Well, on this end, I work closely with the perinatal nurse coordinator.
Yeah.
And so we're a team. So she's the liaison between Peds ID and general Peds, especially when she's making those appointments and even recommending a general pediatrician to the client. So she's very good at communicating that this is what's going to happen. This is what the mother's doing, and the mother is being followed by Peds ID. So she's great at coordinating that care between the two.
Yeah. Yeah, you speak to the key role of nursing. One of the questions I was going to ask all of you is who you recommend clients discuss this with and what resources you recommend for either clinicians or patients. And I think nursing leadership in this and perinatal nurse managers, as well as the physician teams, can be key for that. Are there any other resources that you recommend for clients?
Well, one of the things too is the Wellness Project. That's a website that have inspirational, and it's just been very helpful.
Yeah.
So those things and doing the research there.
My client and I were actually looking, and we found information on the Pampers brand website about tips on breastfeeding. So we went through that last week, and they break it down, and everything was very in layman's terms so she could understand better. So
That's great.
Was a great resource.
I like that too, because we encourage them to do their research, to do their own research with reputable sources out there, because sometimes we know that the internet can be a dangerous place.
Yeah, they can find a lot of wrong information if they don't have guidance on where to look. Yeah. Can you comment a little bit on, and some of you have already touched on this a little bit, but on how your own thought processes about this have changed? How have you dealt with changes in your own mindset about breastfeeding in your time as a case manager?
Well, to be honest, my personal experience wasn't that great breastfeeding. I tried it for, about a month or two. Things happen, nipples are sore and all that. So my thing is just being open and honest with the clients. I focus on education. I want to educate them as much as possible on the new changes and updates and provide them with the updated information. I want to prepare them for whatever decision they make. And also to coordinate all those visits. So I take myself out of it, as far as my personal opinion, and to just focus on supporting my client. If there's a question, I encourage them to write down questions. One of my clients went to the clinic last week and the doctor spoke on engorgement and she didn't know what that meant. So we broke it down and I'm like, okay, that's just when your nipples are sore and, get real hard from the milk and all that. So I basically focus on education and support. Yeah, so providing resources for them. And then making sure that they understand, because sometimes they come out of those appointments and they just have questions, but they're kind of afraid to ask the doctor. So I encourage them to ask me. I'm here. We can look at this together. We can coordinate. If we have more questions, we can talk to your physician together, the nurse or whoever. But I'm here like a main support.
I love that. We really don't want patients to be afraid to ask their clinicians questions, but we know it's truth and that there are questions that they may only feel comfortable asking you guys.
Yes.
Stephanie or Deborah, any thoughts on how your own mindset has changed in this discussion topic?
For me, I was a little scared.
Yeah.
Agree. I was a little scared, but once I started talking to the providers and the nurse and we started like kind of my layman terms, chop it up, what it looks like and what it's going to look like for each individual, just opening up more to those conversations. But I'm feeling comfortable now that I'm sitting in more of the meetings with the providers, the OBs, the doulas and everybody, and we're sitting around having this round table or a Zoom meeting. It makes me feel much more comfortable talking about it because I know that I have the support behind me when I am talking with the client, and vice versa, they have my support as well.
Yeah, but I want to echo what you said. I feel, and I think Dr. Howe would say she agrees, I feel comfortable talking to patients about this, but I still feel scared that something bad will happen to a baby and that it'll be months later that we find a positive baby because of that uncommon but devastating circumstance where transmission does occur. And I think that's why this topic is so serious and so important.
You're absolutely right with that, because we had one client who decided the guidelines were out, but she just took it upon herself to breastfeed and didn't inform us. We didn't find out until she brought the baby in for the appointment. And it was like, okay, we could assist you with this, and she was like, well, I read it myself and was like, no, we could assist you with this, and so that we can lower that transmission. So yeah, I get you.
Yeah. I think I just wanted to address some of the Q&A questions that are coming up. And specifically, several folks have asked, how do you approach a parent who strongly desires to breast or chest feed, but is unable to achieve or maintain an undetectable viral load? So I'm seeing that several times. And that is why we are all here struggling with this topic. So I can tell you what we do, and we meaning what we've done in both an African context and as well here. So in our studies in Africa, and this happens a lot because breastfeeding is the norm, we sit down again and we go through adherence. What are the issues around adherence? It depends on what the viral load is, right? If the viral load is 22, I'm going to have a different kind of conversation than if the viral load is 1,000.
Yep.
But let's pretend it is 1,000, right? This is the nuance of medicine, and this is a little bit of style, right? Stylistic approach. I think many of us in the pediatric HIV world would start to strongly recommend at least holding off on breastfeeding for the time being while that viral load is up.
Yeah.
and I would not feel bad about just sort of saying, if you want my recommendation, that's what it is. You may choose to do something different, but I'm going to tell you that scientifically, you've just shot up your risk much higher as soon as the viral load is detectable in the plasma, right? And so we actually haven't had someone that was that high insist to keep going. And I don't think I've actually had that in Africa either. Some women who have insisted on continuing have been at the cusp, like 25, 30. And we have data showing that their viral loads resuppress quickly. And sometimes you're just monitoring it so frequently that you're bound to see little tiny blips. But remember, we went over this in our last session. The PROMISE study had 2 breast milk associated transmissions, which happened in women who had undetectable viral loads. So this is our concern because there's cell associated HIV in the breast milk. So even if you're undetectable in your blood, we have still seen that you can transmit through the breast milk. So not to be a pessimist, but I fully expect that we may have breast milk associated HIV transmission in the years to come. Not because anyone willingly wanted that to happen, but because we're starting to open up this as a choice and as a practice.
Yeah.
And so I think the best thing we can do is to bring down that risk and educate our clients and patients as best we can, and to walk alongside it rather than sit alongside and be judgmental.
Yeah. There's a lot of good questions in the Q&A that Anne is going to moderate. Before we turn to that, I want to ask Stephanie, Belinda, and Deborah one more question, which is if you have any other patient stories you want to share, things that might be helpful to other case managers or other clinicians as they're thinking through their own experiences with these types of questions. And if you don't, that's okay.
I don't know that I have any specific story that I would share, but just to reiterate, particularly for case managers on the call today, is just continue to be good advocates for your clients. I know that for all of us, this topic brings up a little bit of anxiety and there's a lot of unknown and scary things, but the best thing that we can do is inform people on risks and benefits and things that can happen, and just to support them and be client-centered.
I concur, and be a resource. Always be a resource for your client. Be available when they have those questions and support their decision.
Mm-hmm.
In addition, I would say if you haven't made it a practice to go and actually sit in those appointments, go with your clients to those appointments and really be that physical support for them as well.
Mm-hmm. And I would say, as a clinician who has had appointments like with Belinda present, it is such a better conversation when you guys are there with the patients, because they feel more comfortable asking us questions, they feel, sort of able to speak up in a way that I think they may not if they're by themselves. So I absolutely concur. I know you all have many more stories and experiences you could share, and I know some of the Q&A are for you three, but let's welcome Anne back, who's going to moderate some of our questions, some of which look like they're for Dr. Howe as well. Or Anne, I'm happy to, if you can't unmute.
I can unmute, I just can't turn on my video, which is also totally fine.
Okay.
The first question that came in is, why does intermittent breastfeeding increase the risk of infection? You talked a little bit about that, but less specifically about why, maybe mixed feeding is what we're talking about there.
Yeah, so this was in our first session, but to distill it down, when you go from formula feeding, one feed, and then in the afternoon you go to breast and you go back and forth. I would say there's gut irritability, right? And so we worry about translocation in the gut. And if there's, and this is also why we tell folks don't give your kid cow's milk until a year's of age, right? Because there's micro bleeding, if I were to use that term, in the lining of the gut. And what you don't want is to expose any breast milk virus to a leaky gut where, you know, the virus could transmit it. That's one question, yeah.
The second reason is maternal, which is that intermittent feeding is more likely to result in underlying subclinical mastitis. So infection of the breast that may not even be detected in the form of fevers and redness, and that can increase the risk too.
Those are great points. And probably if you email Estella or you have a chance to take a look at the recording from the first webinar, we talk about that again. So you've got that available. We have a pharmacist who is asking about the fact that she has dispensed nevirapine for the infant while the mother was breastfeeding. And is that in the guidelines? Are we treating these babies that are being breastfed?
Hi, Lynette. Yes, we are. And the reason why I did not dwell on that is because it's all over the map on what the pediatric HIV specialist may want to choose. There are some who would say 3-drug therapy for the entire time of breastfeeding and out past 6 weeks of the last breastfeed. There are some that would give AZT plus nevirapine and some that would only give nevirapine. And there's really no hard data or evidence in large randomized controlled trials for this kind of research question to be answered. But in the guidelines, we do mention, at least in the DHHS guidelines, that some providers would use the WHO extended nevirapine prophylaxis dose. And that I think is put into the guidelines as an option to consider. So we do that in our low risk babies. We would have to think about whether we want to do that in high risk or whether we'd want to increase the amount of ARVs prophylactic.
I think that's a strong endorsement for making sure that if you have a client who is interested in breastfeeding, that we make sure that there is a link to pediatric infectious disease.
Mm-hmm.
Or if we're working with a local pediatrician, that pediatrician has an infectious disease pediatrician that they consult with, so that we're not making things up. We're trying to follow the best knowable policies, because this is a moving target and a new paper might get published in a month that tells us some more good information that might change the practice around treatment of infants that are being breastfed or chest fed.
And that's in the US, right? So because we don't have that much data in the US. Overseas, it actually varies by country. There's some countries that it's 4 weeks of nevirapine and you're done. That's it.
Mm-hmm.
Just keep breastfeeding and monitoring. Of course, they have higher rates of breast milk associated transmission, but yeah.
We have a question about hospital policies, and maybe, Lynn, this is a better question for you. What role do hospital policies play in affecting an individual's decision to breast or chest feed when they're living with HIV? She says, in my labor and delivery nursing experience, unless there's a clear hospital policy, we look for a note that was written by the prenatal care provider.
Yeah. So you are right that hospital policies are really important to how people are cared for on labor and delivery and in the postpartum units, and that when hospital policies are written in an explicit sort of we forbid breastfeeding way, we all know that's not particularly patient-centered, and can result in stigmatized, discouraging language from people who think they're doing the best thing by trying to just follow the policies. So I think my answer to this is twofold. One is it's important for hospital policies to evolve. We at Northwestern, for example, are working on updating our policies to reflect the latest guidelines. And although any big institution, it takes a while to update policies, it will happen. Two is you are absolutely right that documentation by the antenatal care provider is key to helping patients have that transitions from outpatient to inpatient care. And so when Dr. Howe and I see a patient together, we extensively document the conversations, the patient clinician agreement that is made about infant feeding, and we upload all the right documents into the chart that say what the plan is, both for maternal plan and infant medication and feeding plans, so that this is not a surprise to the inpatient team when they're caring for the patient. So in the sort of transition period before your hospital policies have evolved to reflect the latest guidelines, asking the care providers, whether it's the perinatal nurse, the physicians, or other members of the team, to document clearly what the plan is will make all of this easier for patients.
And Lynn, as a follow-up to that, is there a specific protocol for breast or chest feeding that is either part of hospital policy or that is Dr. Howe is part of what is kind of recommended? Because the guidelines are not necessarily written as a protocol.
They're not. And, I think the key thing, and we don't really have a protocol per se. Oh, there you are, Ann. But we do emphasize the importance of exclusive breastfeeding. And so this raises important questions when, for example, maybe breast milk hasn't come in yet and somebody needs to temporarily formula feed, and we have to discuss all of this with the pediatric ID specialist. And then where the protocol really comes into place is in what the infant medication plan will be and how often the maternal viral load will be checked. In our practice and recommendations, we would typically do monthly, although it could be more than that depending on the circumstances for the person, and if they are having social or clinical circumstances that raise the risk for viremia, then we would certainly check more often than that. So if you were to have a protocol about this, I would suggest there needs to be one, a component about who checks that viral load and how often. Two is a plan for infant medication and who will follow that infant. And three would be a plan for supporting the exclusive nature of that infant feeding. So the reason that's sometimes hard to protocolize this is that all those things I just told you about are both inpatient and outpatient, and many times protocols don't sort of cross those realms. And while we're actually talking about mixed feeding, just I briefly mentioned that, I saw there was a question about donor milk. So and I love that question because we deal with this in our NICU too. So donor milk is not considered mixed feeding from the standpoint of infant gut, but it can, if a birthing person is occasionally feeding from themselves and occasionally using donor milk, they can still have that underlying elevated risk of subclinical mastitis. So I think the question really comes into play of how long is the donor milk happening? For example, a NICU baby who is having exclusive donor milk while they're waiting for their mother's milk to come in, and then they switch over to exclusive feeding of their own mother's milk, I think would be a very reasonable approach. Now, there are prematurity issues there that I will let Dr. Howe comment on if that would influence her counseling. But donor milk in and of itself is not considered mixed feeding. It's just the implications it has for the birthing person's breasts.
Thank you. That's great. We have a question about mixed support. We talked about mixed feeding, but where we've got maybe the obstetrician is not feeling it. And now my video is frozen. Sorry about that. The obstetrician is not on board, but the PEDS ID is on board. And maybe this is a question for a case manager, because I imagine that's where the question is going to start. So can one of our case managers tell me how they might address that if you had a client who said, I met with PEDS ID and then I talked to the doctor and the doctor said no?
Well, that has happened. That happened to me before. And so what I had to do was to go back to the thought, this is the client's choice. And the worst thing we would want to do is for them to breastfeed without the total support, because they may do it anyway. So I just felt like I should go back to that first doctor who was for it and then the doctor who was against it, and they communicate with each other and they sit down and talk about that, talk about that particular patient as to why maybe the viral load was too high or this, that, and the other. And they need to have a conversation amongst themselves, but keeping in mind that this is the patient's choice.
I think that's really important, being an advocate for the client And, they don't teach you this in case manager school, but to try to, how to get the doctors to talk to each other,
Yes.
come to an agreement. I think that is something that as a new case manager, you should look to your more seasoned peers to say, it's come up where we've needed to kind of advocate for our clients and advocate for that clinician to clinician conversation. It's tricky.
It's very tricky.
We have a question about, we made the statement with assistance, transmission can be lessened, right? So I think we're talking about somebody who has a detectable viral load. And what is the kind of assistance that we can provide? Because we're not putting pills in patients' mouths.
Well, I think a lot of it is reinforcing adherence and trying to figure out what, are there issues? Maybe she's stressed out because she's a new mom and can't remember to take her pills because the baby's got a crazy sleep schedule. It has nothing to do with her not wanting to. It's just hard to. So what can we do to help with that, right? I think whatever we can do to support the adherence. And then of course, if the adherence is fine, then we have to figure out, is it a problem with the medication? Right.
Yeah, I think this is where our case managers are key, because you guys are often in the homes, seeing the barriers to adherence, seeing, is it some other social determinant altogether? Is it her housing instability, her food access, her childcare challenges that are actually the real barriers to doing all of the things that we need in order to maintain a suppressed viral load? I'm sure you all can speak to
or
that.
Maybe she has, people from Africa visiting her and living in her home, staying with her for the first 2 to 3 months of the kid's life, and she has no privacy. So it's hard to go find a place and take your pill. So it's obviously you guys know this stuff, but yeah, I think the first thing we do when we see a viral load is to go back and go, hey, are you having a problem taking the pills?
Because it's not that, it's
Yeah.
not that they don't want to be adhered to, like you just said, it's not that they don't want to be non-compliant. There's a whole lot going into their lives, especially if they have smaller children in the home as well. So my clients are very honest with me when I say, oops, I see that you had this book in your viral load, and they'll go, well, Miss Deborah, I did miss because this was going on, that was going on, but I plan to get back on track. It was just that. And it's like, well, what can I do to help you? And sometimes they go, really nothing. I know what I'm doing. It's just that particular week was just crazy for me.
Yeah.
True.
I'd be interested in asking the case managers, we have a gamut of women after you talk to them about the whole infant feeding. And have you all been able to have the women talk to each other in that perinatal or postpartum period and see if the discussion amongst themselves actually sort of unsheaths and unearths a wide variety of stances? Because there are some women who tell me, I don't care if you tell me the risk is less than 1%. I didn't work this hard throughout pregnancy to keep my viral load undetected, and now to reintroduce a possible even less than 1% transmission. And they're very adamant about that. Mm-hmm. And then there's other women who are very comfortable with the risk of less than 1%. And so I'm just curious, have you been able to get them all into a room and talk? Because, really they're the ones that are making the decision. And I think Dr. Yee is very adeptly said before, much of this is what's your comfort level with what level of risk?
It's interesting you bring
right?
bring that up, because I have a parent and empowerment group that I have the last Thursday of each month. Nice. And we recently started talking about breastfeeding, and the women are starting to talk to each other. And we have one that said, well, I'm not going to be able to have any more children, but I wish that was out when I was pregnant. And so there's a couple of pregnant women in there that I noticed that she's dialoguing with, like, you should give this an opportunity. You're going to be able to bond with your baby. So she's being very supportive with the ones that are pregnant, you
That's
know, and
great.
may have baby in the future. So they've been talking to each other.
Interesting. Yeah.
Yeah. And
And so-
it's a back and forth, you know, they want to say this, the others say this, but I'm glad that they're dialoguing with each other because they can support each other.
Right,
And that's
right.
what this parenting group is about, to empower each other.
Right.
And so for us, we're just now getting back, you know, post-COVID, where the women are meeting face to face or even on a Zoom, you know, to talk amongst each other. The two women in particular on my caseload that are now interested in breastfeeding, they are interested in meeting each other. So that's something we're going to do next week. So
Okay.
it's coming. It's still coming. So I'm interested to hear that dialogue between the two of them.
It's going to be interesting.
Yeah.
Yeah, it's
Yeah.
going to be interesting.
Yeah. Yeah, because you know they're going to tell us a small snippet of how they feel
Yes.
sometimes. But
Yeah.
I'm just curious, if I were a fly on the wall, what are they saying to each other? And that's why I think golden, because it helps us understand where are we going wrong with our you know, education, if you will, or support. You know, are we not getting at the things that they want to hear? I don't know.
I think you can also capitalize on the support they have for each other for adherence support. And that
Yeah.
sometimes having a peer buddy is a really great way to support lifelong adherence, even beyond this breastfeeding period.
Right. And it's interesting because they both have the same complaint. It's not even about the HIV. They both said, man, you know, I breastfed in the past. That hurts. I wasn't able to continue. And that's when the weaning question came about. Both of them are saying, well, if I can't do this all the way through the 6 months, how do I wean off?
Yeah.
Yeah.
Okay,
Yeah.
Hi, folks. We have less than 15 minutes left.
Great.
All right, let me throw a couple more questions up for you. Do we work with lactation consultants, either prior or post delivery?
Yeah, so lactation consultants at many hospitals are available inpatient, which is great. And of course, we need to make sure they're on board with the changes and guidelines. I will say outpatient lactation consultation is highly varied as to where they are, whether they're accessible, and whether insurance covers it. And I know there's a few lactation consultants in the audience. I would love to, hear their experiences. I personally have found with my patients that it can be really hard to get lactation consultation covered by Medicaid. However, WIC offices sometimes have lactation consultants that patients can access. And once in a while, we'll find private lactation consultants who will support patients. But it is, the US healthcare system is not well designed to support lactating mothers with or without HIV, sadly.
Yeah. There's a couple of questions that are related. The first is, can breast milk be measured for early viral load, or for viral load early post-delivery? And why, because I feel like they're related. Can you address why a woman can't breastfeed with nipple damage if she is undetectable viral load? Can you clarify why they can't breastfeed after receiving a diagnosis of mastitis?
So in terms of breast milk measurements, yes, it is technically feasible to do so. However, in a real-time clinical context, it's really not done. It's more of a, I would say, research context, unless you know another way.
Yeah.
Jennifer. Yeah.
Yeah. But the issue about why can't I breastfeed if I have mastitis is because we are, even if you're undetectable in your serum, in your plasma, is because we're worried about that cell associated HIV. And then once you have mastitis, you've now got a break in your skin, right? So higher rate of transmission, and the cell associated HIV in the breast milk is 10 times sort of more capable of being activated, right? So that's the concern.
Yeah.
In the same way that you worry about having a giant cut on you and you've now got a needle stick, there's a passageway, an entryway. I
don't want to miss the question in the chat too.
Yeah, I see that.
Yeah.
About the, is this Marcela Rodriguez?
Yeah.
Yes, yeah, I know. I saw that too. And I wanted to make sure you are not alone. So I'm going to tell you what many of us have done together in thinking through this on the guidelines and also on the national perinatal guidelines. So I would recommend, if it's a low risk infant, that they do the general, 4 weeks or like 2 weeks now, maybe if you're going by what the new guidelines said, of AZT. And then after that, we switch them to nevirapine daily, extended prophylaxis with the WHO dose. And we keep giving that on out, so long as the caveat is mom is undetectable and adherent, yada, yada, yada. And then we extend that nevirapine dose out to 6 weeks after the last breastfeed time. And then we're checking the baby at 6 weeks and then again at 12 weeks after the last breastfeed time. I think that's a fair approach, if you will, for a very low risk baby. If you have a high risk baby, they're already going to start out with probably the 3 drugs, right, at birth. And you would decide then when you would pull back, depending on what the mom's viral load is and what your birth 2 week and 4 week PCRs are, right? And like I said, some pediatric specialists would say, if they're that high risk and the mom's viral load monitoring is still high, you have to have a real conversation about whether this should continue. And if they're going to continue, maybe 3 drug prophylaxis is the way to go for the entire time. But again, that's a lot of drug toxicity, and that you've got to now monitor. So, yeah.
I think I would also calling the hotline.
Yeah, that's what I was gonna say. Call
the
us.
hotline, call me.
Individual client. Yep.
Yeah, the hotline is available for these kinds of questions. The first line staffing of the hotline is Lori Ayala, our hotline manager, and MFMs, but we will put you in touch with our PEDS ID colleagues, Dr. Howe and others, who can have these one-on-one conversations.
We have a question about, I think that somebody is kind of getting at, this sounds like a lot of work supporting this
It
mom
is.
as a case manager. How do you do it? They want to know, what is your caseload size, Deborah, Stephanie, Belinda? How many clients do you have? Probably total. And then how many are pregnant and trying to make this decision around infant feeding?
Well, the last I talked with you guys, I was at 25 and we're not even at the middle. And now I'm probably about 27 or 30 now.
Mm.
And out of those, I'm probably a good 3 that's interested in breastfeeding, 3 to 4, not very many.
Yeah, I have a couple on my caseload, and right now my caseload is relatively low, but that doesn't mean it's not hard work. But 2 of my ladies are interested in breastfeeding.
I have a caseload of close to 60 clients total. But as far as pregnant clients, in the 2 years that I've been doing this, I've had a total up into today's date of, I think, 9 or 10. So despite serving 17 counties in the state, I don't have that many pregnant clients. And I've only had up until this point 1 person that's seriously considered it and tried to, but had a lot of barriers that prevented them from doing it.
Yeah, that's the other thing. Once they make up their mind to do it and they start, they don't do it very long.
Dr. Howe and I had a patient who only wanted to breastfeed for, was it a month
2
maybe?
weeks.
Yeah, very
2
briefly
weeks
to have that
because-
experience. Yeah.
Well, actually, that one was because that was the amount of time that they were going to have their family from
Visitors.
Africa coming in.
Yeah.
And living with them. So.
Yeah.
Yeah.
And she did not feel at all, I think, sad or uncomfortable to stop, but it was important to start.
Yes. Yes.
We have one more comment in our Q&A, which is how important it is that our case managers get backed up by the PEDS, the ID, and the OB/M colleagues. I think that we certainly have the converted choir on this call, because these Dr. Howe and Dr. Yee certainly see the value of case managers. They understand how much information they have about the clients. They understand that clients may sometimes either tell more of the story to the case manager, or as Dr. Yee explained, clearly are much more comfortable asking questions when the case manager is there in the room with them when they're asking the questions. They feel that support. But I do think that if there's any providers on this call that really kind of looking to that expertise in the case manager is really important, because they do have just another view of this exact same patient. And sometimes we are on our quote best behavior for our providers. We put on our nice clothes, we take a shower, which we don't always do when we visit with the case manager. And we're, trying to be a quote good patient. When the doctor really wants us to be our true self, we're just trying to be a good patient so that we get good care. But we're supposed to get good care regardless of kind of the way that we show up. That's the standard. But please remember to fill out your survey. It is so important that that's actually the way that Maytech gets paid for hosting this program. And none of us are paid to be part of all of this, but we really want to get your honest and true feedback about whether or not we've answered your questions. If we need to have another session with more questions, that is information you can put into your evaluation. If you don't feel like this is answered everything. And then, of course, this is a moving target. As Dr. Howe has said, we are really just getting started here in the United States to really have these conversations and to support our clients who choose to breastfeed and chest feed in the US. And so a year from now, we might have more information and different things that we recommend, different protocols and different ways to kind of go about this that's more based on our experience than in the US than it is experience overseas.
Yes, thank you so much, everyone. And, I want to finish off with what Terry Meyer said in the comments in the Q&A. Terry said 2 out of 1,200 is a very, very low transmission rate. We have to be optimistic. So I end with that. We have to be optimistic. And this has been a fantastic discussion. I'm so happy that we were able to bring everyone together with this conversation. And just know I will be packaging up the recording. The first recording is available, but to everyone here, I will include the registration link to the first recording and include some other materials and updates. And so I will include that in the follow-up email with everyone. I'm a little bit behind on my certificates, but I will get those out as soon as possible. And again, if you have any questions.
Can I just say something really
Sure.
quick? Sorry. I am optimistic. I hope all of us are on this dialogue, but I want to remind us that, the charge is to get to zero. Both in adults and to eliminate perinatal transmission. So while 2 out of 1,200 is small, we want to make sure that we're getting to elimination, right? And so I think all of us, Dr. Yee, we are in support of this, but we don't want to be dismissive of even the small amount of risk.
Sure.
Because it is going against elimination, which is the charge that we've all been trying to do, right?
Getting to zero.
Yes, both and elimination of perinatal transmission.
And 2 is 0, but there 2 is more not 0.
Yes.
And those babies,
they matter.
They matter. Yeah.
Yeah.
Absolutely. So at the end of the day, of course, be optimistic. And for all the case managers out there, all the people doing the work, I tip my hat to you, because that's tough work. And you guys are the boots on the ground. And I have utmost respect for all the work that you do. Really, it is my privilege and my, honor to be able to work on these webinars with everyone, just to bring them out and to share the information with everyone. So as a non-clinician, I tip my hat to all of you and all the case managers and everyone doing the work with patients, because that is, awesome work. And this has been an awesome discussion. So again, with that, I will be sending everyone the follow-up, materials and the recording link and all that good stuff. And if you want to share the recording with like other friends and colleagues, please have them register. Again, if they don't register, I can't count the numbers. And with us, we need to count numbers. So that's very important. But I will send everyone the registration link once this is done, and that way you could share the information. So any other last thoughts and opinions, words, nothing? Okay, well, I guess
Thank you
that's
all.
it.
Thank you.
Thanks, everyone.
Thank you,
Alright.
everyone.
Bye-bye.
Bye-bye.
Bye.